Good morning, everyone. Welcome to the seminar series this morning. It's nice to hear lovely chatty voices in the room. It's nice and sunny outside. It's great that you could be along, and welcome to our folks online as well. I'm Rebecca Pratt, one of the co-associate directors for community outreach and engagement. And this is one of our COE seminars, which we're delighted to be hosting. So it's my pleasure today to be introducing Dr. Kristi Roybal. She's a clinical research scientist at Providence Health Research Accelerator. She earned a PhD in social work from the University of Denver and was a Robert Wood Johnson Foundation Health Policy Research Scholar during her doctoral studies. Prior to pursuing her PhD, Dr. Roybal worked as a community social worker in community development and maternal and child health. She has a huge range of expertise in mixed methods and qualitative research, which, as some of you know, is very close to my heart. So I'm really excited about today's presentation. Some of her recent work includes multi-institution, multi-site studies, focusing on a really lovely range of things, including maternal engagement in the NICU, qualitative geospatial analysis of preterm birth hotspots, and community-engaged cancer equity research. So she brings a wealth of experience to this work. Today, one of the key things that she tries to do is really centre the voices of patients, community members, and providers in her research, which you'll really see in today's presentation, for driving meaningful and equitable change in healthcare delivery. In her free time, she enjoys spending time with her 3 children, partner, pup, and exploring the beautiful Sonoma County. Okay, we're all a little bit jealous now, and taking photos. So a warm welcome to Dr. Roybal today, and thank you for joining us.
You all are having better weather than they are in California right now. So I'm glad to be here and seeing sunny Minneapolis. I've never been here before, but it's a beautiful place. So thank you for having me. Well, I appreciate the opportunity to share our team's work. I want to just start with kind of contextualizing what I'm presenting on. So the title of this talk is Engaging Patients and Community Members in Qualitative Research to Advance Health Equity and Multi-Cancer Early Detection. So we know about 75% of cancer deaths are from cancer types that don't have any recommended screening. And with the national priority to cut cancer deaths in half in the next 20 to 25 years, there's been a real intentional effort, an intensive effort to identify other screening opportunities and recommendations to put forth so that we can detect cancer earlier and beat it. Multi-cancer early detection tests. Today, I'm going to specifically talk about blood-based multi-cancer early detection tests. There are others that include saliva and other kinds of liquid biopsy, but today it's blood-based, just so you all have that context. And I'm going to refer to them as MSEDs. But MSEDs are at the forefront of innovation right now. They can detect more than 50 different types of cancer. The goal is to detect early. They're minimally invasive. They're a blood draw, and so they offer some potential and promise in the way of advancing equity in screening, particularly for marginalized communities and underserved communities who experience the greatest inequities. What we do know about medical and technological innovation in the healthcare space is that equity is often an afterthought. And so those that benefit are those that are financially and socially privileged in many ways. They have greater access. They see the benefit from MSED tests. And we don't meaningfully think about equity as we're developing, researching, or implementing these novel technologies. And so in an effort to advance the field around this and our understanding of what we could do to inform equitable implementation of MSEDs, should they become clinically, should they have FDA approval, essentially, which they don't at this moment. We want to be able to inform strategies to be able to advance that goal of ensuring equitable access to reduce inequity. So that's the context of today. Let's go ahead here. I do want to give a little context about where I'm coming from. So the Providence Health System is predominantly on the West Coast. So you'll see we have a 7-state footprint. We have 52 hospitals across our 7 states, 34,000 physicians, of which 11,000 are employed by Providence, 5 million annual visits, and 28 million patient records. We are a large, complex health system. And so in that way, we're really well positioned to understand the variety of kind of community context that we serve through our services across these states. And it also means that that's a real challenge, that how do we make sure that as a community-based, mission-driven health system, that we're being responsive to community need and local context. And I'll talk a little bit about those challenges at some point. I am in the Health Research Accelerator, and so I'm going to give a little bit of an overview of how Providence's research happens. So this visual is kind of an overview of the Providence Research Network, which spans our 7 states. It includes clinical institutes, innovation centers, clinician researchers, GME research. And then at the middle, you'll see the Providence Research Hub. That's where the Health Research Accelerator, where I'm a scientist, lives. And then the other parts of the Research Hub are our Office of Research Administration, and then our Human Subjects Protections Program. And so as a part of the Health Research Accelerator, we have a team science model. So as a scientist, we always have some kind of technical or scientific lead, and then we have project managers, we have research coordinators, we have data engineers, data analysts, and scientists who really collectively move the work forward. So I just want to be really clear that I'm presenting this work on behalf of our team, and so it would be unfortunate if I didn't say that they've put a ton of work into this. So thank you for allowing us to share our work. And then in terms of our reach and our impact, I really like, I love qualitative research. I'm a qualitative researcher. And so I was really excited to come on board into Providence, where they really want to expand capacity into qualitative research with patients, community members, and providers to really understand the nuance and the context of what people experience in healthcare and how we can do better. And so for me, this quote, while probably not designed with qualitative research in mind, I think does kind of, the take home point is that we're really well situated because we have this real world evidence engine. We're connected with real world care. We really want to understand what works, but most importantly, what works for whom and under what circumstances. And so I think today, or hopefully what I get across about this particular research project is that we're really intent on understanding differentiated and unique needs and being able to respond to that to advance equity. So that's part of what drove me to I left academia. I was at IUPUI for a little bit, moved over to Providence, and it has been a unique context to move research forward. I also am, thank you, Dr. Pratt, but tapped into a lot of varied work. And so this is one piece. We do a lot around cancer equity. And so I'm really, really feel honored and privileged to be able to be in this space and move the field forward. Okay, so now on to the actual study. So I'm just going to set up there'll be questions and answers time. So please know that if I'm light on methods, I'm happy to answer any questions that I don't get to in this kind of high level overview. One thing I forgot to mention, this study was funded through a contract with Grail Inc. So I want to be clear about who our funding source is. Grail Inc. They are a developer of a blood-based multi-cancer early detection test, which has CLIA approval. So they are allowed to offer it. It has to be ordered by a provider, though. It does not have FDA approval. It's in trials like all of the other multi-cancer early detection tests. So I want to be clear about that. And the other part I want to be really clear about is that when we went to patients and community members to understand their perceptions of multi-cancer early detection tests, we did not talk specifically about their tests. We want to understand more globally. We don't know if the Gallery test is what's going to get FDA approved, but something else might. And so we want to understand broadly from an implementation standpoint, how do people perceive multi-cancer early detection tests? So a little bit of background. I know you're all in cancer work, so I don't think any of these kind of main points are surprising here, but we have significant cancer inequities among racial and ethnic, geographic, and socioeconomically marginalized communities, right? And so how do we think about how something minimally invasive, like a single blood draw at a single access point, so an MSED test, how do we think that that might be able to mitigate some of the screening access barriers that these communities experience? So we set out to understand that through this qualitative study, where we wanted to understand barriers and facilitators to MSED adoption. And we also wanted to define effective, I'm getting ahead of myself here. So for patients and community members facing healthcare access barriers, we wanted to explore these barriers and facilitators to MSED adoption. And we wanted to define effective communication strategies to support MSED adoption. And so really I'm going to move through kind of the themes of listening, learning, and acting. And I hope by the end, our team at least is looking to acting and putting some of this work into practice. So these were our kind of key objectives. In terms of exploring barriers and facilitators to MSID adoption, for barriers, we wanted to understand kind of more generally what are barriers to cancer screening, and then we wanted to understand MSID specific barriers. So are there specific things that we need to be thinking about and addressing with this new innovative technology, potentially coming out for people to access? Okay. So a little bit about how we went about our recruitment. We ultimately ended up with 15 virtual focus groups and 85 participants. I forgot to mention this. So our team my team, the research team, is completely remote, and we're operating across a large footprint. Now, we always in our studies take into account the fact that, well, and I love in-person focus groups and interviews. I think they're incredibly powerful, but we also aim to meet our patients and community members where they're at. So we generally will give options around in-person versus virtual. And we actually found for this study that 95% of the people wanted a virtual participation. So I just want to put that out there that we do aim to be responsive. So if that's what communities want, then we will go. But we also, I think, can really tap into the breadth of our footprint by offering this virtual option as well. So a little bit about our recruitment strategy. So we ended up recruiting, our inclusion criteria with that we had to be 50 to 75 years old. We had to live in one of these 3 states, so Alaska, California, Oregon, had to identify as Alaska Native, Black or African American, Hispanic or Latinx. And then the other kind of group of interest or experience of interest was rural patients and community members in Alaska. And those participants could identify with any racial and ethnic identity group or group. So that was not contingent on a specific racial or ethnic identity. And what you'll see here, so I know that this is a little overwhelming, and when I came into this study, it had been pre-designed and the complexity of it was a little, it still is a little. So I'll miss some stuff here. But I want to point out that one thing that was really intentional about this study is that we wanted to stratify our groups by those who are less active or not actively engaged in cancer screening, and then those that were more engaged in cancer screening. So we looked at lifetime screening, we looked at cervical cancer screening, breast cancer screening, prostate, lung, all the big ones that have recommended screening. And so we wanted to really understand if we saw any unique differences between those who weren't getting screened, like other patients in this system. We also, our recruitment strategy, in an effort to be equitable, we had kind of a 2-pronged approach to recruitment. So one was through an EHR query where we recruited patients who met these criteria, then they would complete an eligibility screener to see if they actually, if the data in the EHR matched with what they described themselves, which some people were filtered out. But then we wanted to also make sure that we were engaging community members in our service areas in these particular states who we believe were probably less or not as engaged in the healthcare system. Now, as many of you know, that is really challenging, right? So in California and Oregon, we had kind of a foundation of better partnerships and community partners that we could work with, we could pitch to, we could identify opportunities to recruit community members through. In Alaska, our partnerships are very weak. They don't run deep yet. It has been a harder area to build those relationships and partnerships. And so of the 85 participants, 80 were patients and only 5 were community members. So despite, and I was not on the team at the point when they were really kind of rigorously outreaching community members around this, but for Alaska, for example, I think they ended up having to reach out to like 12 different partners, and it still was not fruitful. Key learning in Alaska was that it is also really hard to recruit participants, particularly Indigenous participants during the fishing season. And so that was a lesson learned. So I just wanted to give you this kind of, well, complicated overview of this study. Again, happy to answer questions about this. Now onto the learning. So we had these focus groups, giving you a sense of what we were seeking to understand through those conversations with participants. We used a 6-step reflexive thematic analysis to analyze our data for themes. Because we were interested in kind of a stratified understanding of what was happening, we had 3 different analysts. So one, myself, took on the actively screening groups, another took on the not actively screening groups. And what I failed to mention in this is that we had several groups that were mixed screening status. And that was a female specific group, a Spanish speaking group in Oregon, and then the rural group in Alaska. So we had 3 different analysts to make sure that as we were kind of being reflexively attentive to the data, that we were really able to be in the space of understanding that particular experience so that we can then collaboratively work on understanding what we might be seeing across both similarities and differences. So that was our objective there. Here, so our thematic findings, you'll see the themes related to barriers and facilitators, we ended up mapping on the socio-ecological model. And we did this because as we were working through our thematic analysis, we were really understanding, and I don't think that this is surprising to anyone, that there are multi-level factors and influences on healthcare behavior and screening behavior. And so having an understanding of where barriers and facilitators exist along in the socio-ecological model can allow us to be more attentive to specific targeted interventions at these different levels of influence. And so that was the objective here. We did, I really want to talk about the application of these findings and what we did with them. And so I won't go into great depth around all of these. And we do, I'm not trying to like tout our paper, but happy to share out the paper where we go into a lot of depth around our thematic findings. But what I want to point out here, for those barriers on the left side that are bolded, those represent overlap between general barriers to cancer screening and MSED specific barriers. So we saw, for example, that at the individual level, adverse psychological impacts, people are afraid of cancer screening. They're afraid of the outcomes. They're afraid of what comes after if they're diagnosed with cancer, or what it might mean, for example, with an MSED to receive a positive signal on a test. What does that mean for my diagnostic follow-up? And so there was a lot of anxiety around that. The other part of the adverse psychological impact that was MSED specific was, well, how accurate are these tests? I don't know. One person was like, I think, leave me out of this for 10 years until they fine tune it. I don't want to be a part of it, right? Because it's going to give me too much anxiety and too much stress to participate in this. So that was one of the specific MSED specific barriers. But we find, consistent with the literature, that a lack of information and knowledge about screening is a key barrier. That negative interpersonal relationships, specifically patient-provider relationships, is a key factor in whether or not someone would move forward with the screening. And part of that is that my provider is not recommending the screening. So that's one bit of it. The other is that patients feel that providers are not trustworthy, that they might be getting kickbacks from industry partners, that they are dismissive, they're not listening, that they're racist and they're biased and they're sexist in their care. And so they don't have these trusting relationships with their providers. So this is multi-layered. And then in the way of other barriers, a lack of trustworthiness broadly at the healthcare system level. This really boils down to racism, sexism, classism, and discrimination in the healthcare system. They also, our participants, specifically in thinking about MSED barriers, talked quite a lot about the Theranos scandal. So what that did in terms of the erosion of a diagnostic blood-based test to the perception that, well, Theranos was a scam, right? They defrauded us. How do I know that you're going to take my blood and not do something nefarious with it, right? And then there's these other considerations around MSED where people thought it was like genetic counseling or genetic screening, for example. And now if I test positive for a certain biomarker, is that going to go on my record as a pre-existing condition? Is it going to eliminate my option to get life insurance or health insurance? Is it going to affect my employability? And so there was concern about the privacy, security, and use of their information from this single blood draw. And so that's an area, an opportunity really for us to do a better job describing what these in fact are and what they mean. And then, of course, societally, financial inaccessibility. I skipped over logistical inaccessibility, but again, insurance coverage, out-of-pocket costs are going to be really big factors here. And then having the time to get off work, for example, transportation barriers. So with the single blood draw, can we mitigate some of those logistical factors by you just maybe going into the office with a typical visit and you get that blood draw as a part of your menu of services for your annual exam? So these are some of the key considerations. For facilitators, I want to point out, a lot of these are going to be one for one, right? Like we know a lack of information and knowledge about screening is a problem, so we need to really hone in on filling those gaps and what's the kind of information that patients and community members are saying that they need in order to be able to move forward with adopting something like an MSED test. I do want to point out that there are, at the individual level, positive perceptions of MSED testing that we can really draw on. So people like the idea of a one-stop shop to have multiple cancers detected in one blood draw. That's promising and that's potential. People are really excited about early detection, and they, the kind of resounding, and you'll see this at the end, the resounding kind of statement here is that knowledge is power. The more I know about my health, the better it can be for me to move forward and figure out what to do next. I then just want to point out at the healthcare system level. So you'll see patient supports. Patient supports was one of our findings that was really specific to our not actively screening group. And what we learned from this group of participants was that they feel like the healthcare system it's too complex. It's hard to navigate. I want to be healthy. I want to get screened, and I don't know what to do. I don't have the supports and the resources to navigate this system. The other element here, which was more kind of diffuse across our participants, was that in the way of patient supports, mental and emotional health are really important. So I'm going to go get screened. I know I'm afraid of this. So what can we do at the healthcare system to provide appropriate emotional support so that people can make meaning, especially if they get a positive result on this test? How do we support them through that process, and not just logistically navigating through the healthcare system, but ensuring that they have those mental and emotional resources that they need to move to the next step? Okay. Again, really, that was pretty high level overview of this. Happy to describe more in questions. So if you remember the second objective, we really wanted to define effective communication strategies. And so what we hear from our participants is we should know about it. All communities should know about it. There was a call out around providers not telling information to certain patients, right? If you're Black or brown or you're a woman, that they're not sharing all of the information. We need equitable providers who will share all of that information. But most importantly, we need to make sure that we're really transparent about what we're learning about MSEDs and how we talk about it with the community. So the more information we can give, the better our participants are saying it's going to go in their way of considering adoption of a technology like this. So in this process, we identified, and again, this was through thematic analysis, culturally appropriate and multimodal communication approaches to engagement and outreach. And so what you'll see here on the left, there was an overwhelming amount of participants who really want to hear about this from the medical environment, their trusted provider, from a medical authority, from a cancer association or the AMA, that for them, those patients and other participants, that they really viewed the medical environment as the source of legitimacy. So if my doctor's behind it, then I'm behind it. If they're going to recommend it, I'm going to get it. So this was a kind of big feature. And then community-based. So I wanted to just, again, kind of, while we didn't quite hit our goal for having more community members involved, I think we did ask participants globally to talk about their experience, but then also their community members' experiences. And what we heard is that for those who are less engaged or not engaged in healthcare, we need to reach them where they're at, and we need to do so. All of our communication needs to be culturally appropriate, but for community-based approaches, we really need to build our partnerships and collaboration with community partners. We need to have trusted messengers to share information about MSED tests with shared lived experiences coming from the same communities, people who look like me, and also people who look not like me. I'm white. People who look like our participants, I should say, but I'm talking on behalf, right? So people who look like me, who have shared experiences, and who also have gone through the experience of getting an MSED test. So what does it feel like to go through this process? How did you handle it? And so I just really want to highlight, in terms of strategic outreach framework, we really want to make sure that these are culturally appropriate and culturally informed. And this pertains to any information we're sharing through the health system or beyond the healthcare system doors. And so this is a really kind of key consideration. So now what do we do with this, right? Now then, these are our learnings. Now we need to act. Right. So our goal as a health system, we're not just learning for the sake of learning. We want to learn to transform healthcare and to transform it equitably. And so a key part of this work was a synthesis of our thematic findings. We took our thematic findings, we spent a lot of time with them, and we wanted to understand how we can leverage this information to design tailored, strategic, and equitable outreach campaigns and materials. And so what we did, I was telling Rebecca that I am not a UX researcher. There was someone at some point on the Grail side who was a UX researcher, and part of what they asked us to do was to develop empathy maps and personas. How many of you are familiar with empathy maps and personas? The same number, none of us were either on our team. So we had a steep learning curve here. And, you know, ultimately, so empathy maps and personas, essentially what they do is they encourage defining unique user segments. So at first I was like, oh, this feels very marketing heavy. And well, it kind of is, right? In some ways, like we're marketing to a certain kind of audience, but it's not the same way TikTok's going to market to us. We want to understand in the way of equitable medical innovation, like how do we connect with you around this? How do we understand who you are as a complex, nuanced person? So we were able to define through our thematic analysis 6 distinctive user segments, patient and community member user segments, where we could kind of deepen empathy and understanding of the motivators, the challenges, the needs, the perceptions of what would support their adoption of MSED tests. And so that, like I said, this was really a challenging task, but I am really confident that this type of practical output is what's going to really translate and have an impact in the way of marketing and strategically outreaching communities around MSED tests. So I'm gonna go through a few of these, but first let me define our user segments. So we have a proactive cancer screener. And again, goal is to think like empathetically about who our patients and community members are that we might be engaging with here. So our proactive cancer screener engages in preventive and routine healthcare, including recommended cancer screenings. This is someone who's very, very tapped into their care. We have a skeptical healthcare engager. So this is someone who might be distrustful of the medical industry and may disengage from healthcare when they feel unheard or dismissed. We have our structurally excluded neighbor. This is someone who lacks health insurance, experiences language barriers, and defers healthcare to meet basic needs. We have our long distance traveler. Again, we were interested because we're in Alaska and understanding the unique experiences of rural patients and community members in Alaska. So these are folks who live in rural Alaska, and they make their screening decisions based on ability to financially and logistically access healthcare in Anchorage, often is where they're heading. A reactive healthcare seeker. So this is someone who seeks healthcare when symptomatic and lacks information about the importance of prevention. And then our lost and alone patient. This user segment was really driven from our learnings from those less engaged in cancer screening or not engaged in cancer screening. This is someone who becomes overwhelmed with healthcare and seeks support navigating the healthcare system. So these are the defined user segments. Now, again, this is just kind of a high level overview. I want to show you some of the tools that we developed. So what an empathy map looks like, and then what a persona looks like. And I'll try and go through 2 of those. Happy to share the rest though with you after this, if you'd like. So for an empathy map, you can see here that we have 4 quadrants. So we have what this person says, right? And these are direct quotes from our participants in our study. What they think as they're thinking about cancer screening and MSED tests, what their behaviors are like in the healthcare space, and particularly around cancer screening, and then how they feel. And because there's a lot up here, I'm gonna read some of them, but not all of them. So for the proactive cancer screener, they say, I really wanna know what's going on with me. I want to help me. I want to be proactive. I want to prevent things, right? Early is important to me because the theory is the earlier you catch it, the better the results. This was specific to MSED tests and the importance of prevention. If I knew there was such a thing as an MSED in January, I'd have done it just because I don't like surprises. So these are things that the proactive cancer screener is going to say. Things that they might think, and again, a lot of these are kind of tailored towards MSED tests, right? Why haven't I heard about these? How come my doctor hasn't told me about these? And we had to tell them that they're really not available yet for them to access, right? So that was a hard one to deal with, but you haven't heard about it because your doctor probably really doesn't know about it yet. And part of the onus of responsibility is on us to make sure that they also know about these tests as they become available and talk with you about it to make sure that you're aware. Will MSED tests replace the other screenings I get? I want to stay on top of my health. I hope MSED tests are covered as preventive screenings or have low or no out-of-pocket costs. How do they work? What's involved? And so all of these different quadrants are touching on the barriers and facilitators that we identified in our thematic analysis, right? Like, what are someone's information needs around MSED tests? What does this patient do? They're going to follow screening recommendations from their provider. They're going to communicate directly with their provider, generally through the patient portal. They're going to consider out-of-pocket costs when making a decision about pursuing something like an MSED test, knowing that it's not FDA approved, so it's not insurance approved. Will it be? And they're going to engage in routine healthcare. In terms of how this person might feel, they're worried about cost. They are optimistic about the possibility one test can screen, this one-stop shop, right? They have peace of mind when they have actionable information about their health status. They're excited about the possibility of a simple and non-invasive or minimally invasive screening procedure. Blood tests are well accepted. Even though they are somewhat invasive, people generally don't, they're not generally taken aback by that. And this person is reassured when a provider proactively discusses screening options with them. So this is a proactive cancer screener. And here's Patty. Here's our proactive cancer screener. And so again, we're distilling kind of key thematic information to really tap into this type of patient and this person's experience. We're humanizing who they are so that we can respond accordingly and meet their needs. So Patty's core needs, again, this is just another way of saying some of the stuff I've already shared, but Patty's core needs are screenings covered by insurance with low or no out-of-pocket costs, convenient access points, like during routine visits or at nearby labs. So this really harkens on logistical access. What can the healthcare system do to make this as easily accessible as possible? So for people who are going in for their annual exams, just pair it with all the other blood work I'm getting, right? Patty's behavior, so healthcare behavior, she's going to consider the amount of out-of-pocket costs when making healthcare decisions, and she sees her provider consistently and follows through with those recommendations. And I think in terms of engagement, how do we want to best reach Patty about MSED tests? How do we want to build her understanding, answer questions? We want to talk direct. The provider needs to be the person who's sharing that message, whether that's directly in an appointment or through the patient portal. So this is a proactive cancer screener. I'm going to show you one more. So the lost and alone patient, again, you see this, it's the same design, right? So I won't go through all of these, but for our lost and alone patient, someone who's really struggling to move through the healthcare system, they really do want to prolong, I want to prolong my life and be healthy and older, right? This is someone who cares about their health. I know it sounds silly, but it would be really scary because it'd be like, well, now what? So this is after a potential MSED positive signal. All these different things that come up with a cancer diagnosis, my gut feelings like, oh my God, now what? Like they're going to be stalled in their ability to move forward because they don't know what to do next. Something that a lost and alone patient might think is there's someone who can help me clearly understand the screening process. I want to stay on top of my screenings, but it can be hard for me to figure out what to do next. Screening feels scary to me. Are there any emotional supports provided through my provider's office or in my community that I can tap into? In terms of what our lost and alone patient does, they might become overwhelmed and disengaged from healthcare because they don't know what to do next. They're going to seek supportive connections to navigate the healthcare system, and they're going to look for that emotional support. They communicate directly with providers. So these are still people who are engaged in the healthcare system. So having provider communication is really important. But the other element of this is having patient navigators or advocates who are available to them and accessible to them outside of traditional business hours to be able to walk through the process as well and have that validation and reassurance and understanding of what the process of getting an MSED test looks like, what would happen if you have a positive signal, and then supporting them should they have a positive signal. And then in terms of how this person feels, they're excited about MSED tests, but they're fearful of screening outcomes. They're worried about coordinating their follow-up care. They're not sure how to do that. And they're stressed and anxious about what comes after screening. So here's Lynette. Lynette's core needs are having a patient advocate or a navigator who can provide really clear information about MSED tests. Coordinated follow-up care would be really helpful. And then emotional support from providers and community support groups or services. Behaviors, as I said, going to be potentially become overwhelmed and disengaged. And again, contacting this person through a direct provider or patient navigators would probably be beneficial. So one thing I want to know about these tools is that they're not mutually exclusive, right? Like we're not going to hand this to a doctor and say, hey, talk to this patient this way, right? These are really to inform how we think about designing outreach strategies, how we think about designing materials to be able to move MSED information and awareness out into the community, how we inform doctors about MSED tests. Hey, this is what your patients really want to hear from you. Here's what you need to understand about these tests. Your patients might experience this range of they might have these kinds of psychological barriers, or they might need additional supports. How can we make sure that you're prepared to support that patient who's in front of you, their unique context and their unique needs? So they're not mutually exclusive necessarily. They're really designed as tools to move forward equitable materials and outreach strategies. And so with that, I'll leave you. So through our qualitative research, we've gotten to the point where we've developed these research-informed empathy maps and personas. Now we need to act on our learnings and that knowledge, right? So that we can equip our patients and community members with the knowledge and information they need to act for their healthcare as well. And so our next step on our project, well, that funding stream has run out, but there's interest now in making sure that, one, we're developing outreach materials that are responsive to what we've learned from our participants, and that we have kind of user experience focus groups to understand, did we get this right? What are we missing? Here's what we learned. What else do we need to understand about putting these materials together? Implement those and see what impact it has on MSED adoption. And then, rinse and repeat. So listen, learn, and act again, and just continually grow in our understanding of what our communities and our patients need from us to ensure equitable access to something like an MSED test. Well, thank you. What questions do you all have?
I have microphones.
I do have a question about that.
Okay.
Hi, Kristi. I'm Abby Benyo, and I love the empathy maps. I don't think you should feel icky about it being marketing at all, because that's what we're trying to do, right? I hope you'll be willing to share those. I'm struck really by, one of your earlier slides. I did take a picture of it, but I was like, this could come from a qualitative paper that I've done about lung cancer screening. Like, I'm actually struck by the barriers, how they're really so consistent, trust and logistical. Like, it's like, oh my gosh, when are, this is what it is. So the great news about that, I think, is that these empathy maps and these personas can be very widely applicable to a huge range of things, and not just MSEDs. I mean, you have some specific stuff in there about MSEDs, but so I think that's great news. Is Providence, demonstrating any interest in trying to fund some of these implementation studies that you're talking about? Because it could benefit them too. From the healthcare perspective, you're thinking about what's their bottom line. Well, if they have to meet metrics around cancer screening, then if they fund your ability to do this and they can hit those metrics, then maybe that will still be beneficial to them, from the bottom line perspective.
Yeah, thanks for that. First, your comment, we were talking about this at dinner last night. We also are doing work in kind of culturally appropriate and equitable biorepository recruitment, colorectal cancer screening barriers and facilitators. And we're going to work on a meta synthesis, because we're seeing the same themes over and over again. And now it's really like, okay, we know, we've learned, now what do we do with that, right? So, and to your question about what Providence is going to do. So we have kind of two approaches here. A lot of our research in the Health Research Accelerator is externally sponsored. So the goal is that, Grail came to us and they said, hey, we want to understand what we can do better too, right? Which is kind of shocking, honestly. They came to us and they're saying this, right? Like, we want to do a better job. And so on the one hand, we can try and pursue funding again. Hey, this work could be really transformative for making sure that your test is accessible to patients and community members. This was the intention. Now let's move on it. So we're going to pursue funding externally as well. And then internally, we don't have a lot of internally funded projects so what I didn't describe really well about the Health Research Accelerator, just because of time, is we provide kind of a variety of services. So on the one hand, we have a research portfolio, and a lot of that is externally sponsored. research. And then we also provide research infrastructure and research services to the clinician investigators across the system, right? To help build their capacity and support them on, different parts of their project that they need support on. So one of our other strategies is, all this information, it needs to go up, right? The ladder up to leaders and administrators. And so one thing that's really, I think, really cool about our model of research is that we tend to partner with our clinical institutes. So in this case, our Cancer and Digestive Health Institute, I actually am partnered with them on some precision oncology projects right now, but we have this really kind of well-developed relationship with them. We also have a well-developed relationship with folks who are doing other work, implementation. I'm actually working on an implementation study related to serial MSED testing for our enriched risk patients. But we also have inroads into the molecular tumor board as well. And so there is a lot of there's a lot of excitement and interest about bringing this information into those spaces to those leaders to be able to one, garner support, but then also identify potential streams to put this into action, test out different strategies. So it's a multi-pronged approach again, and that's going to be how we proceed. I did learn yesterday that we might have some funding to work on these in the biorepository space related to colorectal cancer screening. So again, the findings are really, there's a lot of overlap. So yeah, it's a great question. And I think that that's one thing where our new director in the Health Research Accelerator is really trying to build inroads, because we are such a complex system with our institutes who then give us access to those decision makers who are making decisions about what to do next. And so, yeah.
Does Providence consider itself to be a learning health system, or anybody throwing around terms like that?
The learning health, yeah. So the question is, does Providence consider itself a learning health system? No, I mean, I've not seen us described that way. Now, certainly as the Health Research Accelerator, yes, we're here to learn and then to do with what we learn. And so I think that is the prerogative of our research, but we're not at that state. Yeah, great questions. Thank you.
Hi, thank you so much for a great talk. As someone that researches early detection, liquid biopsy for cancer, this is something that's got me thinking about a lot of things. I have two quick methods questions about recruitment and in the focus groups.
Yeah.
So the first question is about incentivization. Were there any incentives given to recruit participants? And did that vary at all between state or community, or was it consistent across the board? And then the second question is, you mentioned a theme that you saw was distrust around healthcare, which I can see extending to research as well. What did you do within the focus groups to make people feel comfortable being open and honest about what they experience?
Yeah, wonderful questions. Thank you. So yes to incentives. So that is a standing commitment of ours, that we're engaging patients and community members as experts. They're bringing their lived experiences. They're sharing. It is our privilege and honor to hear about their experiences, and we do compensate them through incentives. What we've learned around incentives is people prefer a $50 Amazon gift card, and so that's what we give. Now, in another study related to biorepository recruitment, we had more involvement from some indigenous tribal communities in South Dakota, and we learned different things about incentives. And one is the mindfulness around incentives. So if you give me too much, it's going to deter me from participating. And if you give me the wrong kind, it's not going to help me. If I live on a reservation and I don't have access to whatever big box store, it's not going to help me. I could use a cash Visa gift card instead. That gives me more opportunity. So we are learning. We're trying to constantly learn, but generally, yes, $50 Amazon gift cards is electronic is what we do. And then the distrust around science. Yeah, I didn't get into that too much, but that did come up. So that is a part of this theme of a lack of trustworthiness. So really talked about Tuskegee and Henrietta Lacks. Theranos, of course, also talked about just generally exploitation and research, and this idea, there was concern around, am I going to be a guinea pig in this research? Who's involved in clinical trials? This is something I didn't specifically mention, but in terms of information and building awareness around MSEDs, people in our groups really want to understand who was involved in these trials, right? Has this been tested on people from my community, on Black people, on brown people, on other women, and so there's a real interest in having full transparency. And on the one hand, there was this caution about, I don't want to be a guinea pig. And they thought we were maybe recruiting them into being tested, right? And then on the other hand, this acknowledgement that it's really important for people from my community to be involved in trials so we understand how this works and so that we are benefit of this innovation, which that's a whole other can of worms in terms of that return of benefit. So how did we manage that in our groups? So one thing that was really intentional for our work here was to ensure that we had focus group facilitators with shared lived experiences and identities from the communities that we were talking with directly. And so part of the way we did that was we accessed like our community investment partner teams, health equity teams across our footprint to understand who was doing community engaged work through our health system in those communities. And so we were able to identify actually Providence specific facilitators with shared identities, some Spanish speaking who could facilitate our Spanish speaking groups and came from the same communities and were really heavily invested in community health and community education. And so that is an important priority of ours, is to ensure that, because certainly I recognize that like, well, I'm not gonna like go tell this to this white middle class researcher who's like got fundamentally different life experiences, like what can she understand, right? And there's a lot of responsibility there as a researcher around how do I reflexively engage with like my privileges and what I bring to bear on the research and how I interpret things. And so this is really an important part of our equitable outreach strategies, is to ensure that we have representation on our team and in our facilitators that match or aligned with lived experiences of those we're connecting with. Yeah, thank you.
That was great. I think I have two unrelated questions.
Okay.
Unrelated question number one was, when you set this study up, did you talk about germline screening as well as germline assessment of ancestry?
We did not. This study, we did not wade into that territory. However, people did think that this was germline testing. And so that is an area of opportunity to make sure that this is really well defined in terms of this is not genomic testing, right? We're trying to understand if there's a potential that you have cancer. It's not a diagnostic tool. And so I think we have to be really cautious about what language we're using, how we're describing what it is and what it isn't. And that was the source of like a lot of anxiety around, well, what are you going to do with that information? Like, is it going to go on my patient record? Is it going to have a code on there and then it's going to make it difficult to get life insurance or health insurance. And so this was an anxiety for sure.
Yeah, I did. There are several quasi-prevention studies in the world that do risk assessment by germline screening. And at any rate, you have to make a choice on what level of complexity you're going to do in terms of risk assessment.
Yeah.
The second unrelated question. So your inclusion for participants, were they mostly people covered in your health system, or did you reach out to uninsured and underinsured patients? Because that gets to the now what question. I think a lot of people are discouraged from any assessment of screening because they don't have means to follow up on a positive test.
Yeah, so that's a great question. So that again was our effort, where we didn't quite succeed how we wanted to in really doing community-based recruitment as well, because we recognize that we're missing a whole segment of people who theoretically could be served by our health care system, but are underinsured or uninsured, and they're not tapped in at all, right? So we aimed to do better there, and we didn't do so well. So the majority of our participants are, our patients, they're getting information about this through their MyChart. These are people who are really, or email, right? And they're just more engaged with the healthcare system. And so while we did find that some patients came through who had kind of less broad engagement with the healthcare system, they weren't screening, I think we're still missing a lot of voice from community members who aren't as engaged. And so when we think through how do we leverage this information and these learnings to move forward, that continuing to build our community-based partnerships and ensuring that when we're kind of testing, so to speak, these materials and outreach plans, that we are making sure that we're engaging with trusted messengers who can help facilitate that process so we can gain more learning and information around what we could do to even improve there. So that is a limitation, certainly. And while we tried, we did not meet our full objective on how many community members we could get in here. Yeah.
Okay, we've got a question online from Clement Wilcox. How do you approach communities of color where blood draws might not be acceptable or familiar, such as Native Americans, Hmong, and others?
Yeah, great question. So part of that, part of these conversations was to understand the acceptability of a blood draw. And what we found from our participants is that the blood draw was not a deterrent for our participants, right? That this felt like kind of, but again, we have this skew where we have a lot of involved patients. They're responding through the portal to this study, right? So these are generally more engaged patients. So part of this was understanding that acceptability. From what we learned, the blood draw seems quite acceptable. Now, I can draw on some learnings from our work in the biorepository space, particularly with tribal communities in South Dakota, where the blood draw element and just in general, like giving specimens away it's not, this is not a 1-for-1 here, but there are concerns about what that means for kind of their wholeness and their being and what it means for it to be extractive, right? And so I think there's a question there around, while we did engage Alaska Native participants in this project, I don't think we have quite the breadth of voice from Indigenous communities that we could to better understand acceptability among those patients and community members.
Thank you. This has been really very interesting. I've got 2 unrelated questions too, following along. The first is, did you get any sense of, I'm just kind of wondering, any influence of cancer history, cancer diagnosis history signal in the qualitative data and how that might have played into people's responses?
Yes, so we definitely had survivors who were in our groups. We definitely had participants who have loved ones or friends. Part of the kind of theme around that and early detection was that I just remember this one particular participant standing out, that she described multiple friends who would go to their doctors and they knew that something was wrong. Her friends were Black and Latino, and they knew something was wrong and they kept getting dismissed and they kept getting dismissed. And then it was too late and they had cancer and it was terminal. And so we did hear stories from our participants about, 1, the importance of early detection. 2, and perhaps more important, like doctors listening and being inclusive and equitable and not dismissing their patients when patients know their bodies, right? And so this did come up. We found, so one thing I didn't mention is one of our recruitment criteria was that participants did not have exposure to an MSED test through our health system. And so, like I said, we're doing some implementation studies around the Gallery test right now. And so we wanted to kind of limit exposure to that kind of testing. But what we did find is that I believe 5 of the 85 participants had been involved in a trial at Oregon Health and Sciences University. And so one thing that happened is they came into the groups. And so we didn't prevent people from looking up what MSEDs were, but these folks tended to they were more involved around like germline testing, a history of cancer. They were involved in this clinical trial. And so when they came into groups, they knew a lot about it. And so it did change kind of the dynamic of how people could describe that experience. So I got a little off tangent there, but the point being is that we did see people who had cancer related experiences, and then we saw people who had MSED related experiences, and those both came to bear on those groups.
Thank you. My second question is, the empathy maps they seem like a wonderful tool to really rehumanize qualitative participants. I'm really intrigued and like them. I can see Abby and I are going to chat about them later. But my question is this: it's really, really thoughtful work. So when I think about the empathy maps and I think about the social ecological model, are there things that were hard to bring through from that analysis, thinking about the socio-ecological model, that are about system change or social context, or those broader isms you were talking about? How do you get those to also show up in the empathy maps?
Yes, so I didn't show you all of these, right? But for example, the skeptical healthcare engager. Let me see. Let me show you. Let me see if I can, I might not be able to find it. I think here we go. Okay, from current slide. Okay. Here's Stephen. Stephen's a Black, this is hard, right? So I think we were talking about this last night at dinner too, that part of the intention around the use of the socioecological model is to identify different levers, right? And then to make sure that we're kind of coalescing around everyone who's responsible and accountable to addressing these things, right? And so for Stephen, for example, Stephen has experienced the both long history of racism and exploitation in his family, but also is experiencing that in his contemporary or current experiences in the healthcare system. And so it is tricky to translate this into tools like this. However, the goal here is that by naming it, at least, that I come from a Black family who's been exploited by the medical industry, that by naming it, we can begin to educate and to really intentionally weave that information into how we outreach and engage patients and community members, how we inform providers about MSED tests and the experiences their patients may be having related to racism or sexism or discrimination more broadly. And so I think another kind of important element here, and it's not necessarily depicted, but this is kind of a conduit to those conversations. How do we build cultural responsiveness in our healthcare providers? And how do we also ensure that there's equitable uptake of MSED testing among our providers? And so these are kind of, I envision them as like entrees into having those hard conversations to make sure that as a system, we're understanding that the broader social context is showing up every day in our relationships with our patients, that we are bringing our biases into the clinic, and that we may not think we're biased, but why did I just tell my white patient about an MSED test, but not my Black patient, right? And so I think that these are meant to be dialogue starters so that we can really digest some of how these broader social factors come to play in the clinic setting and in the everyday experiences of patients.
Thank you, Dr. Roybal. That was very informative. My name is Amna Hussein, and I'm looking forward to talking more at lunch. But I had a question around the recruitment strategy for community members. I assume that started with a lot more education about MSED. So can you talk a little bit more about that?
Yeah, so and I will admit, as a team-based model, I came in at the very start of this study and was not involved in that outreaching and partnership building component of recruitment. I will give you kind of the lay of the land, the best I know it from how my teammates worked on this. But the first step was to tap into our network across Providence of kind of community-facing programs. So our health equity teams, our community investment teams, we have health equity teams like spanned throughout our entire footprint, right? And then these health equity teams are tapped into promotoras or community health worker programs. And so then we were able to kind of pitch and build our network outward so that we were really getting to our Providence employees, or we call ourselves caregivers, who are in the community, who are working with the community directly, and then identifying and tapping into the particular community groups that they are engaging and working with. And so, for example, in Oregon, we connected with the health equity team. Through that process, we identified Marisa, who is Spanish speaking, she's Latina. She is a promotora in communities and works with specific groups. And so she was able to go directly to those groups to recruit people into focus groups. And so that is kind of the model we used. There was not a lot of intentional education around MSEDs. We provided a pitch to these partners. Hey, what do you think? Is this something that might be worth asking about, essentially? But we didn't want people to have tons of information about it because we weren't sure what that would mean for our understanding of like the baseline understanding. Now, a lot of people Googled it, and that's fine. But that was the model of expanding from our kind of inward network outward into the communities. Yeah.
I hate to ask you this kind of question that goes into the political realm, but this slide and something you said just makes me think about this. So obviously, administrative attack on DEI initiatives is in full force.
Yeah.
Do you think there's a distinction in anybody's mind, the difference between health disparities and what is viewed as DEI at administrative level? And how do we, I'm asking you as an expert who works in this field, but how do we as a community make sure that our legislators at a federal level understand that, one, health disparities exist and are important to address, and secondly, part of the way to address that is what you said there through trusted messengers, which I think is partially a DEI initiative.
Yeah. We went deep there, but it's understandable. This is important. This is important. It's all political. All of it is political, and to like deny that would just be not acceptable. I wish I had a good response for health equity matters. I don't know that we can convince some people that health equity matters, and they've proven to us in our current administration that that's not what matters. However, I think for the rest of us who are doing this hard work every day for our health system, we're not backburnering or dismissing the kind of criticalness of equity in the work we do, because it not only is just an important part of being a community-driven, humane health system, it's good for everyone. It's good for all of our communities to drive equity forward. And so from our health system standpoint, you know, there's obviously, I'm sure you're all getting all your emails about what's going on and what you're doing and what your administration's doing and not doing. So I don't know that I have a great answer for you. I think that humanizing the experiences of patients and community members, more importantly, having them tell their stories whenever possible, not me as the researcher telling their story, but whenever possible, humanizing that is what drives policy change. And so as someone who's also trained in policy translation and community organizing, there's nothing like the power of a story and your lived experience. And so how do we find ways to connect with our legislators and policymakers in that way? Now, this is hostile right now, so I don't know exactly how great that's going to go over, but I think it should at least push us to fight harder.
Thank you so much. I'm getting the sign we're at time.
at
Thank you
time,
for a
yeah.
wonderful presentation and a really lively and deep discussion. That's just really fabulous. I think you've given us a little glimpse into the future. So thank you so much for coming and sharing this work.
Thank you for having me.